trends in hospital charge capture. And some of it's getting back to basics, and some of it's going to be about thinking completely out of the box and taking everything you know about rev cycle and kind of throwing it to the curb and starting new. So the description we talked about will show a direction towards enhanced analytics. That's key. Analytics are coming into rev cycle like nobody's business, with cost, with charge, with pricing, with CDM. So we're starting to see that. And we're going to cover some of the levers that we can manipulate to get this. We're going to do our usual overview of charge capture, understand the move to non-hospital services, and review people, process, and technology. This is really the approach that most people are taking now to be able to create their revenue cycle. So when we took a charge captures, this is a typical charge capture revenue cycle. And it starts with patient access. And we're going to talk about that in a minute. But we see that the blue section here, we don't involve them like we should. And so therefore, we're going to see the first of the purple and the blue. I'm going to focus on that because, quite frankly, that is the new trend in revenue cycle, is to call it clinical revenue cycle or clinical determinants of revenue cycle. There's a number of buzzwords out there, but basically it's having the clinicians drive the rev cycle instead of the rev cycle trying to chase the clinicians. So the new trends are back to basics. You know, where are we missing in charge capture? What types of tools do we need? What types of people do we need? The biggest obstacle to charge capture is and continues to be silos. So if we want effective charge capture, the silos have to go away. We see that more action steps have to be implemented before patient you face-to-face. You're going to have to start as the first interaction with that patient, be it by phone or be it by email, however that is. I use clinical revenue cycle here as just a catchword. There's clinical determinants of revenue cycle, there's clinical driven revenue cycle, and there's all sorts of things that we can look towards. The bottom line here is we're going to move from patient financial services to patient access. And we see, according to HFMA and Revenue Cycle Intelligence and all their contributors, we see early identifications of patterns of behavior. And we want to move to more focused things with data analytics. We're going to focus on net patient service revenue, but that's what we've always focused on. Now we're going to see the cost to deliver services. And the first time that really became observant to the general rev cycle population is in the PREPA report, and what your cost to provide is, and are you within the 20th, 80th, where do you range nationally on that cost to deliver? So more people are looking at cost to deliver, especially in value-based care or risk-based agreements with payers. We want to enhance our audits and cause for root cause. So there's many solutions out there and many audits out there that find the problem over and over and over and over again daily that goes into a queue to work, like the Rev Guardian queues or whatever, but we never seem to fix the problem. And we still see that even at today, 1 to 3% of net patient service revenues on the table. So when we look at this, there are interdependencies. If you have a weak link in people, it doesn't really matter what your process or your technology is. If you have a weak link in process and no policies and procedures, then the people are going to behave erratically and the technology is going to just work the way it was designed. So these interdependencies are the new rev cycle. And what I want to talk about today is I want you to forget what you did with rev cycle and start to think outside of the box and start to think, what is the clinician's role to move our revenue cycle forward? Do they work with IT to create the templates? Does IT have a team of clinicians that constantly look at the things, not the informaticists that design it, because they only design what they think should be the end user? What is it doing? Why aren't they reconciling charges? What is the problem with this charge capture? Trauma activation, critical care, do they have a flow sheet that represents it? So I want you to start thinking in terms of clinically driven revenue cycles, CDRC. We start with the people, and it's only as strong as your weakest link. So we start with patient access, the clinical revenue cycle, then it goes to rev integrity and patient financial services. In the past, the bottom rung was where we did all this stuff. It was like a black hole. Everyone said patient financial services has that, they'll fix it. I don't need to really own my charge capture. My documentation isn't up to par. I don't really need to own that because somebody's going to help me later. So this trained, learned behavior that it's going to be fixed on the back end, that's gone. That is no longer a trend. The trend is now to start at the first link and make it as strong as you can be. So when talking about the first link, we have human intervention and creation of the revenue cycle. It can only be supplemented by technology. So you do not want to drive your revenue cycle around the technology. So you're not going to create your revenue cycle to make the technology work. You need to make the technology work for the revenue cycle. We're seeing a much stronger trend towards education and certifications. And what I see really grown in the last decade is NAHAM. That's patient access and their personnel. In the past, it was kind of like light duty, or we had occasional workers. If we had full time, they were the supervisors. There was a huge amount of turnover. There was a huge amount of error. And we started putting technology in to kind of fix some of those tasks. But NAHAM changes the whole thinking pattern into education that will improve patient access and provides a certification. So that's making that first link that we know from history that is not as tight as it should be. This is one step that you will use to get the people as educated as highly effective as possible. HFMA put out something, and I can't find anything after 2018, but at one point they said that up to 40% of the claims can have registration related errors, be that demographics, eligibility, authorization. And one of the things we see is that with eligibility, a lot of times you have a system for eligibility and patient registration, but the Medicaid system has a different system and Blue Cross has a different system that are direct dial-in. And so they have to leave their screens to do it. So this is one of the areas that we see eligibility fall. The other one is what we call first of the monthers. That's where states such as Arkansas, you can change your insurance every month. So if you want a different insurance every month, so if somebody registers for a chemo on the 28th of the month before and they come in, that old registration is going to be what's brought up, but they don't have that insurance anymore. Clinicians, departments, or staff are seldom included in the full scope of revenue cycle discussions. Frankly, when I talk to clinicians, they don't understand what I'm talking about. So there is a significant amount of education that's going to have to go into the clinicians as to why they're doing it. They are there to provide excellent patient care, and they have been burned out through COVID and a number of different things. So you see that the documentation is really a struggle now. Some of these electronic medical record systems are so complex that it takes them longer to document than to see a patient. So we're going to see the clinical revenue cycle, or CDRC, they're going to start to get involved and try to make these more efficient. We're going to continue to focus on documentation and clinical activities associated with charge capture. Is this really what you're doing? And when I say clinical activities, I also include supply chain and pharmacy. Are the drugs correctly coded? Did we charge the right amount? What about supply chain? We find more often than not, the C codes on supplies are erroneous. Because somebody didn't check the manufacturer and make sure it was the right one. We see the people are going to be our clinicians. So now nursing, cath lab, EP lab, the nurse practitioners or the PAs, peri-op services, pharmacy, clinical documentation improvement. And I always hear, well, that's an inpatient event. No, there is a move and trend now towards outpatient clinical documentation improvement. So you really need to embody that as too. Managed care, social services. Excuse me. We have to take in the social determinants of care and see what that's going to do and how our cost to provide care. Radiology, lab, ER services. All of these things are important. So for example, with population health, if I send a diabetic out and they have no money and they're homeless and they're living on the streets, I guarantee you that EMS is going to bring them back into emergency services for a visit. So we need to start looking at what is that outreach with communities. Clinicians, while that was a prior listing, clinical groups need to figure out what area they're responsible and does the documentation meet charge capture. You are instructed by multiple organizations to not document for reimbursement, but to document for quality care. And I mean, one of the examples I see are daily progress notes from the physicians. No change overnight, follow along with you. That's not documentation. You know, how does that meet a plan of care? Nurses are used to plans of care, so are physicians. The plan of care has to be there. And when we're looking at documentation, we have to also think about, can that service be provided in a lesser level of care? Why am I keeping this patient in observation or the hospital? What is the result of end organ damage or permanent malady if I send them home with home health? So we have to start seeing that. So we're going to see that a lot in CDRC. HIM and coding, they're the subject matter experts for the coding, and they can say what they need to code. But again, we need to understand what are the basics of documentation. I've been through SOAP, I've been through DOAP, I've been through a number of different models to document. And what I'm starting to see is when I started my career 25 years ago, 30 years ago, I was taught SOAP as a PA. It's coming back, surprise, surprise. Coding is based on well-documented standards. So what is the standard? Am I documenting? And then the coding personnel are put at risk of under or over coding because if we leave areas for interpretation. Revenue integrity, it's still a group as charge capture and pre-billing edits. Reconciliation is still a very big task for them to limit the leakage. We're starting to see RI staff become coders or clinical background, compliance background, denial experience. So we're seeing the composite revenue integrity used to be just analysts. We're seeing that change quite a bit to meet now this clinical driven revenue cycle. So they're going to have some of the elements of the clinician. Professional organizations such as HFMA, AHIA, and NARI are focused on revenue cycle outcome, and they provide a lot of training as well. So we're going to start to see people getting more involved with these organizations. Information technology is the essential skill set. It's the essential link for all the processes within revenue cycle. It creates documentation templates, right, wrong, or indifferent. And it creates document-driven charging, which is really the ultimate best practice. Is if I reach a certain threshold in documentation, it's going to charge. That documentation will be based on coding standards and quality outcomes. One of the silos historically has been IT created the processes to make the software work and hum along, but it was not complementary to the human process. So an example is when I used to dictate, I could dictate a patient's record in the cardiology in 5 minutes. Now it's taking me 15 minutes when I'm seeing them face to face because I have to do all these things, and a lot of them are for statistics that are not really relevant. It's not for the community standards. It's for some internal mechanism, and they just keep getting added on. It's never a refresh where we're going to look at these and say, do we still need these? They just keep adding on. So the documentation becomes an onerous process. And if you look at the burnout among physicians, which is extremely high, we see that documentation is the #1 cause of burnout. So we want to be careful if we're going to do clinically driven revenue cycle that this is provided. Key to performance improvements are two groups. I like to get some Six Sigma people in to do root cause and say, is this the most efficient process? What is this process? Why are we doing this? I ask clients a lot, why do you do that? Well, because of this, that, and that. And I said, well, is that relevant to your revenue cycle? Well, no, we've been asked to do that for years. Well, why are you sending this report out email every week? Who's looking at it? So you go to the designated in the email and you ask them what they're doing with it, and they said, oh, we haven't done anything with it for years. So, I mean, there needs to be really a focus on what's necessary. Then we have project management or enterprise project management, EPMO. They look at the root cause from Six Sigma and performance. They put together a work plan to ensure all the aspects are covered, check the box, and it provides a source of going back after the fact. Key people strategies are integrated teams bringing skills together for a synergistic result. That's clinical driven revenue cycle. That is the goal of it. Bring everyone together and let's get this moving. Ongoing education, training, and cross training. So I know the coders learn the new CPT codes and they learn the new procedures, but do the clinicians understand what changed and how that might change their documentation? Continued second person review to identify weaknesses and retrain. And this is one area where the CDM is just, you need a second person. I have somebody reviewing the mappings between my clinical revenue centers, be it the lab module, radiology module, OR module, supply module. I have them look at those links between that and the charge master and then the charge. So a lot of times we'll see the supply chain change something, but then go ahead and give it the same HCPCS code, which is incorrect. Or we'll see preference cards that contain a number of items, but some of those items no longer exist, so they're charging in lieu of or something like it. So this is where I use second viewpoints. They're able to identify root causes with limited data and should have the authority to recommend root causes. A computer system can only identify patterns of behavior. They're not going to identify the root cause. So when I look at it, human capital is your weakest link in the revenue cycle. It's constant review of control points. And that's one of the things I see. Coming originally from accounting, what's my internal control? So do I just let somebody come in and make a deposit and I don't write it down? It could go into the teller's pockets, they could share it at lunch, or does it go in the bank account? No, I have an internal control that posting has to show that, and that then the customer gets a receipt. The next step in the revenue cycle is to review the prior steps. So we see in really effective revenue cycles, especially in ER and surgery, where the first person who interacts with the patient after EMTALA or whatever reviews the registration with the client. And when they review the registration, they don't say, hey, what's your insurance? They say, show me your card. Tell me your address. What's your date of birth? And most clinicians are already confirming date of birth and things like that. A failure identified should be assessed by a group and root cause identified, and retention efforts are key to growing the revenue cycle. So underpaid, undervalued personnel at the front end is going to guarantee what I call a GIGO, garbage in, garbage out outcome for your claim. So focus on putting the right person in the right role at the right time for the right position. And when I start to look at your labor, which is your people, it's more than just FTE counts. I look at the labor. I look at staffing contracts. Am I having to do a lot of outsourced staffing because of COVID? Is that my major cost? And then outsourcing. Is there a portion of the revenue cycle that it's not effective for us to be doing in-house? Should we be taking a portion of that and looking at that? Should we look at a third party? What should we do with it? So labor is one of the three components of the total revenue cycle. And I want to point out here that quality is too. Your clinical operations, your patient safety, your population health. One of the things in charge capture that we see a lot is with ACOs or system, are we sending that patient out of the system for their follow-up? So they come into the ER, they don't have a doctor. Are we just leaving them with no one, or are we making an appointment for them to come back to our system and retain the patient and the revenue? Labor management is going to be key, and it's not just FTE reduction. This knee jerk that I've seen year over year over year, I'm not meeting budget, I'm going to let staff go. What does that do? That means other people have to assume roles. That means there's gaps in your processes. It may or may not be covered. It may be abrupt, and you don't have any process to cover it. You want to focus on training and retaining and managing roles. Labor management focuses on efficiency, not just reduction. So when we're looking at acuity in the ED, that's revenue cycle. And are we understaffing consistently, overstaffing? And for that, there are tools out there that look at it by 15-minute increments. And they can look at your historical patterns on certain days, certain months, and say, okay, at this time frame between 2:30 and 4:30 in the morning, I really only need 2 nurses. But I have 5 on. And I have 3 registrars. That's a point where you adjust your staffing. Outsourcing can be considered, but it still needs to be managed by the facility. And that's one of the things I see a lot is, that people outsource it, they write a check for it, they don't manage it, and then the outcome is deficient, and they're like, well, what happened? You have to own it. If you're going to outsource it, you need to own it. So if I look at an accounting revenue cycle, okay, this would be the control points. Patient access. I'm going to do a control point after that to assess whether all the elements at that patient access were completed. Then I'm going to go on to clinical driven revenue cycle, and I'm going to do a control point. Did all the clinicians document what I needed? Then it goes to revenue integrity, and they're going to do a control point to see if it's all captured before it goes to the billing cycle. So the key here is your control points. Now, human nature. You experience errors and failures. Say somebody calls in sick and that person has to do 3 people's job. You're going to have high volumes, client facing pressure to complete. So when you've got somebody sitting in front of you registering, the goal here is to get it done as quickly, efficiently, and politely as possible so they have a positive experience. Well, sometimes we get going too fast and we make these mistakes. Complex software with incomplete training. So where somebody trains you for an hour by IT on your software, you're put into your job or you're put into the software the next day, and you really just know basics. You really need to have your super users in place. Patient comes first, so the documentation may be incomplete, prompting groups such as CDI to follow up. Each step of the revenue cycle must review the work of the prior step, and I've been through that a number of times. But one of the things we see a lot is you pick the wrong patient ID, Smith's, Jones, whatever, or it's somebody else altogether. And maybe you picked the wrong account number. And on their last account, they found out that you were allergic to penicillin, but you copy or open the account that doesn't have the penicillin allergy, and you have a legal issue created. So this is very important. The number of duplicate medical records that HIM deals with daily is pretty significant. The number of John Doe, Jane Doe conversions is significant. So this is something we seldom think about, but presents a huge quality risk, if not a legal one. So internal controls are necessary. Each step in the revenue cycle has to look at the prior step, and we've talked about that. So clinical revenue cycle needs to be completed before HIM coding going on. It does no job to code it, but one of the things I see with the coders is because the op report isn't done, they read they can't code from the preliminary, so they kind of code from the description, and it's not the complete description. We could have had a different code. For each action, you have to look at the prior step. And one of the things I use when I implement this process at hospitals is I use literally a pilot's checklist. It can be for any plane you want, but there's a pilot's checklist. And if they miss one single element, they have to start the checklist all over again. So say they're on the runway and they go and they're doing their pre-takeoff final check, and they find out that they missed a step during taxi. They have to go all the way back to the gate concept and go through all those things. So there's not a problem. Now, you wouldn't want the pilot to make a mistake because that can cause casualties. Well, you certainly don't want the medical record to have a mistake because that's going to cause preventable illnesses and or harm. So a lot of the cost of medicine today is in patient harm. And so you want to look and try to mitigate that. And so I use a checklist. And most people don't like it because it's too organized, but we do it anyhow. So I've done the people. We're going to move on to the processes now. And if the people link is strong, then I can move on to processes that involve the people. So people require structure to reach the same objective, no matter how it's approached. If you just say to somebody, enter your charges, and you don't give them specific instructions of what needs to be entered, when and how, you're going to get disparate outcomes. So processes such as policies and procedures provide these structures. Now, we all know that when I was a nurse in the unit, we had huge red binders of nursing procedures, and only if we got in trouble did we look at them. Half the time we never read it all. So you don't want to become voluminous. You want it to be a teaching aid and help. So you don't want just to have this huge policy that nobody's really checking on. You want it to be helpful. So policies and procedures for eligibility check. You may decide, because the Blue Cross people have to go to a different eligibility check than your software that you use for registration, you may want to send every Blue Cross to one person who knows how to use that system. Processes to confirm the identification is correct. Key to processes is a policy and procedure. So when I look at this, the policy is the highest level. And that drives your procedure, which is the how to do it. And then you look for consistent outcomes through a consistent application. So if we're doing the procedure the same way, such as trauma activation, I need the critical care, it needs to be documented, the out of network, out of community has to be documented. Those are all in the policy. Then I have a procedure of documenting when the EMS activated it. When did they get there? What did they do? And if I follow these two through the trauma, then that's consistent application. I'm going to get consistent charge outcomes. The policy and procedure acts as a standard for which to measure the outcome. So if we're going to go audit it a few months down the line, I have a standard. And I'm going to audit against that standard and say, is there an aberrancy or pattern of behavior that's actually happening that we did not consider, that's either creating a negative or positive result for which we want to change up the procedure? So Webster says it's a definite course or method of action selected from many alternatives in like-given conditions, a guide and determine present and future decisions. Policies and procedures are dynamic. They are not static. So if you get a new service line, you're going to need to change the policy and procedure to include it. It's just a standard that provides a benchmark, and it is key to your internal auditing and internal controls. So when I look at charge capture audit, you set the standard, the policy and procedure. You measure the current practice against the standard. So what is actually happening? And does it match the standard? You compare the two results and you change the practice to the best practice possible and you re-audit. What happens here in the dark blue is many people have fires. And those fires are like, okay, I did all this and now I've got a new problem. And so I'm often running to the new problem and I never go back and redo the blue. And what we find is human nature is to go back to an area of prior comfort. And so this thing may have come completely unraveled. So this is part of getting back to basics. You need to just stick with the basics. Point of service cash collections, an example policy. If you use the HFMA, patient friendly, is defined to measure collections occur as early in the revenue cycle as possible. So if you're doing an elective procedure, have that financial discussion with the patient saying that when you come or before you come, I'm happy to take your copayment now, but you'll need to have that before we can do your procedure. Point of service collections decrease the instant the service is provided. Then it's into billing and you have to chase the patient and what have you. So you want it to really happen as soon as possible. If there's a copay and deductible after the ER visit at the time of discharge, usually the discharge registrar goes to the bedside to create the discharge papers, and they can collect the copayment at that time. They need to show the acceptable co-mates and deductibles, and you need to strive for 98% or greater cash collection per location. Some people are as low as 50, some people do 100%. Clinics, ERs do better on point of service than clinics do, because people say, oh, I forgot my credit card or whatever. So you need to be able to try to let them know in their clinic visit instructions that you will be collecting cash, and you ask for the opportunity to collect it before the visit. Any patient access staff are accountable for following the policy. NAHAM has a number of point of service policies. Go out to your organization. Don't recreate the wheel. See what best practice is out there and learn from it. So auditing POS cash, we use this cycle to make sure that if there's an additional intervention. Here's one for emergency. Under OPPS, stated the following guidelines for charging. In the absence of national guidelines, we need to see patterns of hospital visits by reporting levels above and below that would appropriate and differentiate for these services. So there are 11 points that CMS has said that most payers follow. So we would want to follow those 11 points as a policy and procedure. Charge capture process. Policies and procedures are key to processes for medical necessity. So are we doing medical necessity ABN at radiology, or are we just missing that a lot? Charge capture, charge reconciliation. So I saw one the other day that the patient had charges and credits 10 times on one charge. So you want to see what happened there. Is that a systems issue? Is that a person issue? Is that what happened? I mean, why did it happen? And we saw quite a number in a couple of days, and they actually had a systems upgrade that caused it. Documentation, get your input from CDI and coding. Don't just have CDI chase the docs around to improve their documentation. CDI needs to be teaching everyone what is the best quality outcome. And it's not just CCs and MCCs. So I see a lot of CDI people just focus on CC, MCC, and case mix. That isn't the story. There's a lot of quality metrics, and when we start collecting quality scores here at Health Catalyst, we can start to see what are the outcomes for quality. What did we do? What's a patient safety metric? All that goes in to that 3-tier thing that I showed you before with labor, a revenue cycle, and quality. The policy-driven charge capture process has to include all this. So, you're going to have policies and procedures and patient reg and attended by a nurse and physician. So we've done the policies, we've done the people, we've made them strong links. Now comes the technology. And what I want to point out is more often than not, I see the technology driving the processes, and then the process is driving the people in not a fashion that is consistent with their clinical delivery system or their skill set. So basically, we amended the clinically driven revenue cycle to meet the requirements to make the technology work. That's not the answer. The answer is to work with your vendor and get the technology to work with these first 2 steps. And that's your first step. It's the last of the 3, but this piece performs in a predictable and sustained fashion. So it's not open to variability by a person or a process. It is absolutely positively going to happen the same way every time, the way the technology was designed. Now, if you implemented it incorrectly, it's going to implement wrong, and you're going to get a wrong result. But that's the technology itself is solid. It never changes. Unlike people and processes, it only does what it's told to do. So I'll get something in charge capture. Well, it didn't catch this. Okay. Well, did we use AI or rule to catch it? Well, no. It only happens every now and again, and we know about it. Well, then you have to adapt the technology to take that into consideration. Again, technology does not drive the process. The process has to go, and the people have to go first and then design the technology. Types of technology that we see divided into a couple pillars: the charge master and charge master maintenance. One source of knowledge centers to look up and obtain current regulatory information. So this is a point for me with technology here at Vital, where we have Vital Knowledge, and it's a one source lookup for knowledges. But what I'll do is I'll go and I'll see CPT books from 2018, and I'll see ICD-9 books there, and I won't see the latest. And so how could you possibly get the right answer if you're using outdated stuff? Rules are AI based on charge capture. They're standalone technology. Okay. They're standalone, supplemented by the consultants. That's another method where the consultants and the technology work together to a point where the vendor will drop off. There's technology in which daily reports are reviewed by certified auditors. So there's technology where there is actual, you pay on what they find, but they're never going to fix the problem. They're just keep telling you what's wrong. So technology isn't one term. It's really important to know what technology you're getting, for what purpose, and what clinical decisions and processes have to be reviewed. So when I look at this, here's two areas. Now notice it happens after the light blue and the purple. We get the CDM and the pre-bill. But if in fact the charge entered the staff automatic through an ancillary module, and that module is radiology, and a OneView chest X-ray has in the CDM a 2 view, then every time they charge the OneView and it's linked to 2 view, you're going to be charging a 2 view, but you won't have documentation to support it. So this piece in the middle, I should have made it red. This piece right here, the linking is at least 25% of the errors I find, especially in pharmacy units of service where there's a mathematical calculation. So CDM is your first line of defense. Most hospitals take it very seriously. The OIJ takes it seriously, and they took it seriously back to 2005, saying outdated CPT codes or deleted codes or incorrect charge capture is actually leads to compliance issues. CDM software that maintains charge is in a compliant state by scrubbing it at regular intervals. We have people that send it weekly, monthly, whatever you want to make sure you're up to date. Looks for outdated codes, deleted codes. And here, pricing becoming really important now with hospital price transparency. You do not want a CPT code in your hospital price transparency that is 10 times what your neighbor charges. So you want to look now, strategic pricing is becoming very prevalent. It's been forced by HPI to get your strategic pricing, because most of strategic pricing has been done by volume. So our highest volume services are increased 4% every year, and our lower volumes are increased 50%. So that we keep up. Well, that doesn't work anymore, because you get things that get completely out of control, like the $50 aspirin or the $300 chem panel. And so strategic pricing and pricing disparities is important. So there is the standard analytic file that captures all the charges that go to Medicare. So you want to be able to compare it with your peers, but it won't drive your charging practices. But you can see if you're off. Now, one of the problems with HPI and with charge review is that it's not the same. It's absolutely not the same. So you could have one hospital that puts every single supply into the OR procedure, and another hospital that charges the procedure plus the supplies, and it won't look the same when you compare the CDM. It's supposed to look similar in the Hospital Price Transparency or Price Transparency Act, because you're supposed to take the ancillary items and bring them in. So there's a lot going on with pricing now. Risk areas for the CDM are still pharmacy with units of service, supply chain, and I go back to pharmacy. One I see all the time is dexamethasone. I think it's J1100. it's for IV use, but I'll see it for a Medrol dose pack or something like that. That's oral, that's self-administered. So I see coding there. I see supply chain with inaccurate supply charges for the coding all the time. When looking at supply chain, you're going to want to look at the manufacturer, the model number, use a lookup, use the FDA lookup, and find out what that HCPCS is. Operating room services could use a clinically driven revenue cycle person in the OR, perioperative services, as a full-time employee, because they need to work with preference cards, they need to work with charging pattern, they need to understand physician practice pattern. And so we frequently see a significant bump in revenue and decrease in cost when there's a CDRC person there. Operating room services are known for charging errors, charges for items that were never used. You know, what's your policy on that? If you open it up but it doesn't touch the patient's body, do you still charge for that, or do you not charge for it? And because outside payers will do a charge level review or line item review, and they'll say that wasn't documented as being used, I want you to take that off. So you need to have a policy and procedure on how you charge it. VitalWare frequently sees that non-vascular ablation catheters are coded as vascular ablation catheters. So that's where the word ablation is steering supply chain wrong. Is it a vascular or cardiovascular one, or is it a non-vascular? We see this all the time. We see pacemakers being inaccurately coded quite a bit. We see the J codes for oral medications when they should only apply the injectable. But the biggest charge loss in pharmacy are units of service. And we'll see if it comes over as a unit of 1, but you were supposed to have 40,000, that doesn't work. You have to go ahead and get that going. CDM management tool is successful as the people that know how to do it. Outside reviews are required at specific intervals. So if you have a CDM, our recommendation is always that every 2 or 3 years, you have somebody from the outside with a fresh set of eyes look at it and say, well, what's wrong with this, or what could we do better? Must have personnel that are familiar and embody the process of the clinical revenue cycle. Many vendors have charge capture technology. Consignment based is what they pay when they find something, and then you charge it, but they get a percentage of that reimbursement, but there's no incentive for them to ever help you fix it. Their incentive is keep finding it, so you keep paying for it. And then non-consignment subscription based is what we're seeing more often. You pay a flat fee, and then there's no charge for finding. The key for any charge capture technology is it must consume 100% of the daily charges. So every single charge that goes through that day at that facility goes into some sort of technology to review, whether it be AI, rules, or a mixture. The targets are usually CPT, HCPCS, ICD-10, ICD-10 PCF that appear on the claim. That's the trigger, okay? And sorry, that's the trigger. And then the target is what's not on the claim. So I actually have that one backwards. In many cases, the combination is multiple triggers and multiple targets. So it's one to many. So the key here is to get a trigger that is something that appears on the claim, and we'll look for a specific target. And if that target is not on the claim, then it will fire. So I do apologize for this slide. It is backwards. And Marie, I think we can update this and send it out. Here's an example of amniotic membrane. The device is missing. I have the amniotic membrane procedure, but I don't have any device. And so in this case, one of these CPT codes appeared on the bill, but the target was not on the bill, and it's a lost charge. So when we look at technology supporting people and processes are the foundation. You build the technology around the foundation, amend new people process to ensure optimal benefit, and then re-educate constantly. And super users are in this red. You really need to have a super user with consistent training time. And in many cases, I'm seeing hospitals actually do charge capture examination as part of the yearly nursing or PA or whatever certification for your yearly benchmarks for your job. So I'm seeing that more and more and more where there's a simple charge capture questionnaire and they go ahead and fill that out. Technology results in a complete clean claim. So we know we focus on a clean claim, and a clean claim is looking for things that are on the claim that don't belong together. We're talking about a complete clean claim, meaning nothing was left off when we did that examination. So you can slice and dice it with technology by service area, high dollar, high volume gross, directionally correct net, any period of concern that you have, and it might work with compliance. Patterns of behavior are easily seen both in compliance rules and revenue cycle rules, and it promotes the root cause and not just continue to work a revenue guardian at it day after day after day. Here's an example by service area. I only have one case to review, but it's a whopper. It's 3,000 gross and 9,000 net. Here, I've got IV therapy where I have 112 high volume. This pattern of behavior is losing $164 every time for those 112. So whether it's one with a high impact or many with a lower impact that becomes high, this helps you see in the service area summary. High dollar, we showed you the high dollar, and that's a concern. And most revenue integrity people work them first. But if it's in a department and you have a CDRC person in the cath lab, they'll work the service line for cath lab and make sure they're all correct before they go out. High volume, you've got an IV issue. What is the issue? Is it the charging? Is it the documentation? Is it coding getting behind? What is it? So I've given you an example of the 5 W's here that are great for understanding how to get to the root cause. And you ask a question and then you answer it 5 times. And the answer you get on the 5th time is more likely the correct one. So in summary, we're looking at current and future trends, depending on alleviating silos, focusing on the interdependencies of people, process, and technology. And we're looking at continuing focus on decreased revenue. And we have to encompass cost management. While revenue is being pretty well capped, either by fee schedule or payment regime or contract, the cost to provide is well within the scope of the revenue cycle. And that needs to be examined. How much is it going to cost us to provide this? Do I have a physician who takes 5 times longer than the resident to do a procedure, and that cost to perform is much higher? What do we need to do to look into that practice pattern? Do I have a physician that only uses the latest and greatest pacemaker when one that's been established and costs lower is in fact just as efficient and just as successful and just as safe? So we're going to look at quality outcome. We're going to look at HCAHPS. Do I have patients constantly complaining about an element of my revenue cycle? So that's in the clinical driven revenue cycle. What are those HCAHPS scores telling me? Facilities tend to run from fire to fire, and they frequently do not complete the full implementation. So what we're saying, the new trend is, after COVID, I'm seeing many, many hospitals just completely pause, and start to look at every aspect of the revenue cycle and how they can do it better. Because up till now, we've had the CDI silo, we've had the revenue integrity silo, we've had the billing silo, we've had the charge master silo, we've had each department as a silo, we've had patient access as a silo, but we've never looked at it as one complete piece. Integrating CDM and charge capture process and people management allow for sustainable outcomes, meaning that when that person comes in adequately trained in the morning or at night, they consume 100% of the daily charges. It identifies patterns that they can bring to upper management to start to correct. It enhances compliance by making compliance more transparent. So if you are failing to get the medical necessity diagnosis code from an LCD repeatedly over and over and over again, that's something you can detect in your compliance actual charges. Key takeaway, a sustainable process must involve skilled personnel a state-of-the-art technology and a best-of-breed outcome. And in order to do that, you now need to think out of the box and get whatever you can involved in the revenue cycle. So I see we have 4 minutes left. Marie, there's one question. What domain is this under AHEMA? I don't know, Darren. We'll send out the CEU and it should probably be able to answer it from there or call it AHEMA. In terms of questions, how do we get CEUs, CEUs? CEUs will be presented if you completed the session, and Marie can go through that. We're cutting in and out. Every webinar we have with you is choppy and cut up. Can't understand. Crystal, I think we need to probably work with you. If I don't see anybody else having that issue, but we do want to address that for sure. Slide deck is available. Marie will send that out. Recording will be sent out. Sound is fine. How can one create targets and triggers within the system? We use Cerner for documentation and RCA. Would this be something that we would reach out to Cerner to build? Generally not Cerner. There are vendors out there, we're one of them, where they have created through their coding people hundreds and hundreds of thousands of rules. We have 1 million combinations. Cerner will give you a template to create your own, but the problem becomes the rule maintenance and correction. So maybe you make a rule today and 6 months from now, the coding change. So generally these are add-on technologies that work with Cerner to do these RCA things. A lot of thanks, and I do appreciate that. Pharmacy units of service for Miss Pulaski. Hello there, Brooke. Pharmacy units of service are an issue. We see the issue being created from the dispensing unit to the billing unit description through an algorithm that takes it out into a combination. So for example, ondansetron, it comes in a 2 milliliter vial and 4 milligrams. That is the dispensing, is 4 milligrams. However, if you charge it as 1 vial, you're going to get 1 unit. If you charge it by the cc or milliliter, you're going to get 2 units. But the correct unit, according to the billing description, is per milligram. So you'll get 4 units. And what I see a lot of times is that these algorithms for mathematical calculations do not actually calculate correctly. I see this a lot with weight-based chemo, just a ton with weight-based chemo. I see it quite a bit with rituximab. I see it with some of the newer drugs that get paid per 5 milligrams or whatever, and I'll see 4 units on the bill, but there's actually a calculation difference that only comes up to 20, but you deliver 200. So units of service are very, very, very important. And I find about 25% of the revenue that I find when I go in and do consulting for revenue integrity, I find that to be one. I know I had one client about 1.5 years ago. It was $1.4 million in one chemotherapy net that they went back and rebuilt. So that's it. What is, Brooke, you're killing me. What is the best source of truth? Payer guidelines, CMS guidelines. That is your best source of truth. After that, so you're going to start with CMS guidelines, go to payer guidelines, because they will differ somewhat from the actual requirement. So if you have a 340B requirement, that's going to be your guideline. Then from there, you're going to go to the MAC level, Medicare Administrative Contract. Do they have any articles or literature that I can use? From there, you can go to your professional organizations. I frequently see that a vendor, while they're always high efficiency, they can make mistakes too. So you want to double check your stuff with like maybe a supply chain or with CMS or whatever. But I frequently see the fact that there is no policy on what your hierarchy should be for obtaining articles. So when you can look at this from your appeals people, they're going to start with CMS guidelines, then they're going to go to the payer guidelines, then they're going to go to the MAC guidelines, and then they'll use community stuff. So anybody that gets to a level 3 judge, advocate judge, they know these how to do this. Brooke, what? No questions more? Brooke and I used to work together. She likes to ping me. I had a bad thunderstorm. Okay, no sound. The targets and triggers, what part of the solution does that encompass? So that's technology. You're going to have your best foot forward, best of breed. You have your policies on what should be charged, your procedures on how to charge it. You're going to then have your people trained in that. And then you're going to take your targets and triggers. And what we do at our firm, if we implement, we go through your targets and your triggers with you. There may be 185,000. We go through and we say, okay, this came out as a target or as a trigger, but I'm not seeing this target. Oh, it's C1776. Oh, that's a joint implant. Why did you use a joint implant on a live birth? And so that was a charging error. So we'll go through and we do create root cause remediation sheets. So the targets and triggers look for the coding aspect or the charging aspect. You can do it by CDM number that looks at a trigger on the claim that is missing or has the incorrect target. Brooke, I don't know if that answered it. Inside outsource versus in-house proactive measures. If it's outside outsourced, you got to own it. So your revenue cycle still needs to own it. You still need to make, remember they're vendors, they work for you. So if suddenly they say, we found you $3.4 million in reimbursable cash, go to your 835s and find out if that's right. Because if it's not, it's just a figure they're using for their contract. So be very careful. There's Brooke. She finally appreciates me at the end. I use an exception report to capture charges that exceed a certain dollar amount. I have based it on, makes sense, like 1 unit from endo versus 10. I likely have less than 100 idle. And most of our people in a facility side, like a whole like 300 bed hospital, they're going to have about 300 cases a day, most of which are the same thing, or they can figure it out. We see quite a bit on Monday because we get their daily charge file that they actually had charging issues with per diems or PRNs on the weekender programs. So we see quite a lot. So it can be as little. I have one client that's about 250 beds and they're getting 50. They've cleaned it up. And then I've got another 600 bed one that's getting about 800 a day. Final knowledge. Yes, Susan, thank you for that. And that's all the questions and we're right on time. So with that, I'm going to end the show. And Marie, I have to jump off. A drug that doesn't have a HCPCS code or available billet units, usually if it's unlisted, it's a unit of 1, unless the manufacturer says otherwise, or you have a directive from Medicaid. All right, I've got to run to another call, but I appreciate you being with us. Marie, you want to end the session?
I will. Yep. Thanks everyone for joining us.
Is that it?
Can you hear me now?
Yeah.
Okay. My microphone wasn't working. Yep, that's all. We'll send out the CEUs and the link to the recording and slide deck. And that'll be out by end of today. So thanks everyone for joining us.
Thank you. Appreciate your time and bye-bye.
Bye.